For decades, the biological definition of Alzheimer's disease has focused on a specific sequence of events in the brain. The prevailing model targets the creeping buildup of sticky amyloid beta plaques and tangled tau proteins among neurons as the primary initiators of cognitive decline. Recent clinical trials reflect massive pharmaceutical investments aimed directly at this pathology. Modern monoclonal antibody therapies successfully target and clear these mature amyloid plaques from the brains of symptomatic patients. Yet removing this debris in the late stages of the disease only yields an incremental slowing of cognitive decline. The heavy plaques are cleared out, but the overarching neurodegeneration continues its progression. Amyloid is undeniably a core component of the disease, but the clinical data suggests that clearing the downstream protein debris without addressing why it accumulated in the first place means we are arriving at the scene of the injury decades too late. To find the actual starting point, researchers have turned away from late-stage clinical trials and looked at community-based autopsy studies of older adults. These studies reveal a consistent physical reality: an aging brain exhibiting isolated protein plaques without any other structural damage is extremely rare. The standard condition of the aged brain is a state of mixed pathologies. Along with amyloid and tau, the vast majority of cases feature severe vascular damage, including large vessel atherosclerosis and networks of small vessel microbleeds. The biological signature of Alzheimer's does not appear in a vacuum. In a substantial subset of patients, the famous amyloid fingerprint is the late-stage result of a systemic vascular failure that began long before the first memory slipped. If we rewind the clock to a healthy midlife artery, we find the origin point of that vascular failure. The primary driver is a structural protein called Apolipoprotein B, or ApoB, which sits on the surface of every atherogenic lipid particle in the bloodstream. This visualization compares standard LDL cholesterol mass on the left with ApoB particle count on the right. Standard LDL measurements track the total mass of cholesterol inside the particles, but arterial damage is dictated by the total number of circulating particles. A higher ApoB count means more individual particles bumping into the vessel wall. When these excess particles crash into the endothelial lining of the artery, they get trapped in the subendothelial space. The body responds to these trapped particles with a sustained inflammatory response, gradually building up an atherosclerotic plaque to wall off the injury. Because this buildup happens microscopically over time, the most accurate predictor of vascular risk is cumulative exposure, measured in ApoB years. The longer the vessels are exposed to high particle counts, the larger the physical blockages become. Atherogenesis is an issue of volume and duration. The total duration of high ApoB exposure mathematically dictates the eventual structural degradation of the arteries. Atherosclerotic damage propagates through the entire cardiorenal cerebral axis, linking heart and kidney failure directly to the health of the brain. Look at the carotid arteries in the neck. Their complex branching geometry naturally creates turbulent flow. When ApoB-driven plaques form here, the high-velocity blood tears small pieces off the rough plaque surface, firing recurrent microemboli directly up into the brain. Simultaneously, identical plaques form at the narrow openings of the renal arteries. As blood flow to the kidneys drops, the kidneys misinterpret the blockage as a systemic drop in fluids and artificially spike the body's overall blood pressure to compensate. The localized blockages in the neck and the pressure spike from the kidneys merge into a mechanical feed-forward loop. The delicate microvessels of the blood-brain barrier are now subjected to chronic high-pressure pulsatility. Following that hyperpulsatile flow up into the cerebral microvasculature, we find vessels that have lost their elasticity. Decades of chronic pressure and plaque accumulation have rendered them stiff and rigid. This rigidity disrupts the glymphatic system, a perivascular plumbing network responsible for washing daily metabolic waste out of the brain tissue. The glymphatic network does not have its own pump. It relies entirely on the rhythmic, elastic pulsing of healthy arteries to drive the clearance process. When the upstream arteries stiffen from ApoB plaque, the brain loses the mechanical force required to flush out its waste. The accumulation of neurotoxic proteins is a direct consequence of this mechanical failure. Without stable arterial elasticity to wash the brain, amyloid and tau are trapped in the tissue, concentrating to toxic levels. The evidence linking this vascular timeline to dementia comes directly from genetic data. Researchers utilize Mendelian randomization, studying the natural genetic variations passed down at birth that act like a lifelong clinical trial. This chart plots the dementia trajectories from over 1 million individuals. The steep curve represents people genetically predisposed to high lifelong ApoB levels, showing elevated cognitive risk. The flat curve tracks those with genetically determined low ApoB levels, who experience drastically lower rates of clinical dementia. The genetic data establishes a causal relationship. Decades of clean, unobstructed blood flow actively protect the brain from neurodegenerative decline. Because the damage accrues over decades, dementia prevention requires a shift away from exclusively targeting late-life neurology. The data points toward early cardiovascular intervention and midlife blood pressure control to maintain arterial health. We can modify this risk directly. Clinical follow-ups show that adopting high-quality, plant-forward diets, like the MIND dietary pattern, actively lowers systemic inflammation and slashes cumulative ApoB exposure when implemented early in life. By the time cognitive symptoms emerge, the structural damage in the arterial network has been compounding for 40 years.